I'm Dr. Richard Beaser, Medical Director of Continuing Medical Education and Senior Strategic Advisor for Educational Programs at Joslin Diabetes Center and Associate Professor of Medicine at Harvard Medical School, welcoming you to today's programs. Joining me today are my distinguished colleagues and friends. On my left, Vivian Fonseca. Vivian's Professor of Medicine and Pharmacology and Assistant Dean for Clinical Research at Tulane University School of Medicine right here in New Orleans. To my right is Andrew Moshfeghi. Andrew is Associate Professor of Clinical Ophthalmology and Director of the Vitreoretinal Surgery Fellowship Training Program at the University of Southern California's Roski Eye Institute in Los Angeles, California. Welcome, Vivian and Andrew. It's important also to recognize that the slides and practice aids are going to be available and downloadable after today's program. And that's part of the Seeing Their Future educational initiative. So now we can move on to the program. Today's program is really going to address some of the gaps that there are in the coordination of care for people with diabetes in getting their eyes screened and getting proper eye care when necessary. And there are a number of gaps that we have to address, and first we have to identify them. Diabetic retinopathy or macular edema is present in nearly 30% of all people with diabetes aged 40 years and older in the United States and is the leading cause of blindness in adults of working age. Inertia. We've all heard of clinical inertia. As many as 50% of people with diabetes in the United States are not evaluated for diabetic retinopathy despite the known risk of vision loss. Referrals. Diabetes specialists do not treat diabetic eye disease, and the late presentation is recognized as a common barrier to optimal eye care. Expertise. When diabetic retinopathy is detected and treated early by an eye care specialist, the risk of severe vision loss is reduced to less than 5%. So today's agenda is going to address many of the issues involved in overcoming these barriers, examining the roles, screening guidelines, and pathways for diabetic retinopathy and macular edema care, the spectrum of eye diseases that may present in people with diabetes and the progress that's been made in managing these conditions, current and evolving standards for ophthalmologic screening in people with diabetes, and how timely referral and diagnosis are critical to minimizing or preventing vision-threatening complications. And then the role of multidisciplinary and interdisciplinary care models and a patient's perspectives on diabetic retinopathy. We're going to discuss the importance of working together to preserve sight through screening, referral, and treatment, as well as coordinating diabetic retinopathy and macular edema care across healthcare teams, providing practical applications of key themes discussed today through case discussions on managing diabetic retinopathy and macular edema, and then we will conclude with a question and answer. So let's start off with some comments from Andrew talking about the current state of retinopathy screening. Andrew?
Thank you. So as Dr. Beaser just mentioned, in the United States, despite knowing all of the horrible manifestations in the eye from diabetes that can occur, that we're only getting about half of patients screened appropriately, getting that annual dilated eye exam. And we can see that this is not a trend that's necessarily improving in a significant fashion, even though we've known about this for quite some time. So this is still a vexing problem. And this goes across the spectrum from diabetologists to ophthalmologists to optometrists, as well as obviously the patients themselves. So diabetes, we know, is a huge epidemic, not only in the US, but around the world. And similarly, we tell you from our experience in our offices as ophthalmologists that we see a huge amount of diabetic retinopathy and diabetic macular edema in our offices, such that in 2018, the estimated prevalence of diabetes was 10.2% or 27 million cases. And globally, there's about 2/3 of a billion patients with this condition by the time 2045 rolls around. And retinopathy develops 10 to 15 years after the onset of diabetes, which may not be necessarily when they were first treated for it, but when they were likely first afflicted by it. With the increasing prevalence of diabetes, we find that more people are at risk for retinopathy, and that requires greater resources to identify and treat this. So we know that persons with diabetes are at high rates for vision-threatening eye diseases. A lot of people don't know, but diabetes is a risk factor for lots of conditions, not just diabetic retinopathy. Certainly, people with diabetes are much more likely to develop cataracts at an earlier age than they would otherwise develop them outside of a diabetes diagnosis. And this leads to vision loss the greater the duration of time that the patient has diabetes. And the same is true for glaucoma and other conditions. But what we're really concerned about is diabetic retinopathy and vision loss from diabetic retinopathy, which also includes diabetic macular edema. You can see in those red column graphs that, up to 12% of patients after 10 years of diabetes diagnosis are going to have some diabetic retinopathy, and 6% of those patients are going to have actually vision loss from diabetic retinopathy.
So there are a number of risk factors that promote the development of retinopathy. Vivian, can you tell us a little bit about those?
So the most important, from my perspective as an endocrinologist and diabetologist, is glycemic control. And there are obviously other things that are important that I'll come to. And the degree of control matters. So in people who have good control of diabetes, the risk of retinopathy is relatively low. But bear in mind, duration also matters. So if you have good control or reasonable control for a long period of time, you're still at risk of retinopathy. And if you have very poor control and you have it even for what is deemed to be a short duration of diabetes, your risk is high. And we can use this when we get into issues like how do we need an urgent referral or not so urgent referral? Part of the problem is we often don't know about the duration of type 2 diabetes, and we also don't know very often what antecedent control has been. What was your patient doing 3 years ago before he came to see you? Was he well controlled or not? And that information is often missing. There are other factors that are important. Dyslipidemia, and we'll discuss treatments of lipids, and the same with hypertension, are well known to be associated with retinopathy. And there are many studies now documenting this, as well as intervention. Strangely, high LDL cholesterol is associated, but LDL lowering with, say, statins doesn't change that very much. So these are associations, maybe telling you that this is a high-risk patient and also is at high risk for getting retinopathy. So but it's important to keep it in mind. And when we think about it, there's a wide range of things, chronic hypoglycemia, obviously, and hypertension, and we can do something about that. Long duration of diabetes, we can't do anything about. They've already got diabetes, and time keeps moving on, and age is a factor there as well. Nephropathy is very interesting because as you get advanced CKD, your risk of having retinopathy is more. It just means diabetes complications often occur in tandem. It's very rare to see somebody with one complication and not another. So that tells you your patient's got a low GFR, they're likely to have retinopathy. They really need to have their eyes examined. And we'll discuss lipids in a moment.
All right, so having heard that, which of the following methods is preferred for diabetic retinopathy or macular edema screening by primary diabetes care professionals? And I'm using that term, primary diabetes care professionals, so the people that are taking care of the diabetes, whether that's a diabetes specialist, endocrine diabetologist, or PCP, or whoever. One is the Amsler grid, 2, Snellen chart, eye chart, 3, direct ophthalmoscopy, 4, a comprehensive exam with a qualified eye care professional, or 5, I'm not sure.
Well, direct ophthalmoscopy is only helpful if you actually see some retinopathy, but if you don't see it, that doesn't mean retinopathy is not present. So you really need a more thorough, either a dilated peripheral retinal exam or through some of the telemedicine approaches, through non-dilated approaches. But really, for the purposes of this question, comprehensive exam with a qualified eye care professional would accomplish.
I totally agree with you, Andrew, but let me just say that we should not forget how to do direct ophthalmoscopy.
Oh, I agree.
The acutely ill people, it's sometimes useful. Someone's in hospital and they got CKD that's unexplained. You may find hypertensive changes that are pretty advanced. It tells you about your patient's risk. You know, we grew up without all those fancy gadgets you have in your office today, and we use that old-fashioned ophthalmoscope. And today we're not training people properly. How do we even hold an ophthalmoscope?
No, it's so true. Excellent points.
But ultimately, the qualified eye care professionals is good, but it's a good point. We still have them in our exam rooms.
All right. I think it skipped forward there a little bit.
Just hit the backward.
All right, we'll go forward.
No, you got it? All right. Oh, you got it. There you go.
All right. So, you know, with respect to who are people participating in the screening and or management of diabetic retinopathy and diabetic macular edema, there's lots of different folks involved, including my colleagues here on the podium, diabetes specialists, also primary care physicians. Then, you know, there are non-MD physicians such as optometrists that are very prevalent throughout the United States and available to see patients frequently. And they are able to diagnose eye diseases, appropriately refer patients that require it to a more higher level of care, and can treat selected eye diseases. Opticians are really those who help you at the optical shop, help get you fit for glasses and teach you how to use contact lenses, but they're not going to participate in the screening process per se. And then obviously you have ophthalmologists, and within that Venn diagram of ophthalmologists, you have subspecialists such as myself who are retina specialists, retina surgeons, and then we have all sorts of other subspecialists such as glaucoma specialists, cataract specialists, pediatric ophthalmologists. And some of these folks, depending on where they are in the country or in your community, may be participating in the annual screening process. Others may say, well, I just focus on if you really have a serious eye problem, I don't do the screening, but it will vary. And so this is nice to refer to know who all these different folks are. So unfortunately, for screening purposes, if we rely upon the patient's symptoms alone, that's actually a poor indicator of whether or not diabetic retinopathy is present. Because early on, when all they might have are dot blot hemorrhages in the peripheral retina, maybe some cotton wool spots, that's not really going to cause them to have decreased vision in a way that they would bring it to your attention. And by the time they actually do have the more salient symptoms of more advanced diabetic retinopathy, like floaters, flashes of light, sudden change in vision, loss of the peripheral visual field, and blindness in the extreme case, it's really like really far along at that point. And at that stage, we're kind of behind the 8 ball. And so even though you are detecting it, and that's good, even if it's for the first time, it's really quite late in the process, and they would have had a better outcome if we had picked it up earlier. So symptoms alone are not great, but if they do have these symptoms, obviously they do require an urgent evaluation. There's lots of different society-based recommendations for screening for diabetic retinopathy. There's the American Optometric Association, we have the American Academy of Ophthalmology, there's the International Council of Ophthalmology, and they all have these different flow charts and diagrams. It can get a little bit complicated, but they all share several things in common with consensus recommendations from the American Diabetes Association, which basically tell us that if you're a type 1 diabetic, you basically want to have that screening exam around the time of diagnosis, certainly within the first 5 years of diagnosis of type 1 diabetes. For type 2, again, we want to have that as early as possible, even earlier than type 1, just because patients may have been walking around undiagnosed for quite some time and may already have some retinopathy present. And then if no retinopathy is present, fine, let's see you back in 1 year or even 2 years if you have really good control. That differs a little bit from the American Academy of Ophthalmology, which says no matter what, you should come in once a year. But if you just remember 1 to 2 years with no retinopathy, that's reasonable. And then if there is some retinopathy present, then the doctor will make appropriate recommendations based upon the level of severity of retinopathy for when to come back. And then during pregnancy, if there's either gestational diabetes or a diabetic patient who is pregnant, they're generally going to be seen at the time that pregnancy is detected as well as quarterly thereafter.
Yes.
Did you have any further comments on that, Viv?
Yeah, I think there was a little bit of confusion when the ADA changed their recommendation to 1 or 2 years. And I think I was surprised when that happened, but I think it's not a bad thing because, for one thing, it makes us look a little better when our patients don't go every year, particularly somebody very early in the disease. Patients do miss. It's an extra burden to go for another visit to a doctor again. You're telling them, go to a dietitian, go here, go there, and they don't really want to have time to do that. One way around that is the recommendation about teleretinal screening and things, which is now really dramatically changed in the last few years. It's accurate, very sensitive. So if you've got a large practice that has many people with diabetes, it's cost effective to have the machine in your office, train some of your staff to take in a picture, and it goes through the telephone line, not yet Bluetooth or through your cell phone, but I've seen papers where people in Africa and other countries, parts of the world, trying out using your phone, sending it to an ophthalmologist who will grade them. And initially, ophthalmologists protested. They said, no, this is not good enough. But it's good enough in some ways where there are 3 possibilities. You got retinopathy, you need to come and see us soon. There's no retinopathy, it's all very clear. And you might miss a little bit at the periphery, I accept that. Or the quality of the picture is not good enough, you still need an eye exam. And I think if you recognize that, you're not going to get it 100%. You will at least achieve more screening metrics than what we are currently doing. So that's really very useful. And there are a number of other things that are coming in. Artificial intelligence to look at your picture and tell you immediately what kind of pattern you've got. Eventually, artificial intelligence and computers going to take over everything. So you won't be doing screening anymore, Andrew. You can, play golf most of the time.
That's right.
Well, let's hear a patient's perspective on this. We have Fikri, who's going to speak to us about some of her impressions.
My name is Zineb Fikri. My current age is 30 years old. I'm a professional singer and I'm on my 2nd master's at USC in opera. I was diagnosed with diabetic retinopathy at 28 years old, or turning 28 years old in 2019. I think both my optometrist and I noticed different things around the same time. And as far as anyone following up with me, it was just the same optometrist. But I see my endocrinologist every 3 months, up until recently, which has now changed to every 4 months. I can speak to my endocrinologist very openly about my diabetic retinopathy with whatever concern I have, but it's mostly him asking me how my vision is doing, and I report accordingly. the only form of communication is through me. I am that bridge of communication. So if my endocrinologist needs me to ask my ophthalmologist something, then I do so, and vice versa.
All right, so I think we hear a story that sounds familiar to many of us, and there's a lot of rationale to improve our screening for diabetic retinopathy and macular edema. It's a significant problem. It's asymptomatic. There are severe consequences of untreated disease, as we've alluded to. Historically, there's been poor follow-up among patients with diabetic retinopathy, and the ability to preserve vision and prevent adverse consequences of diabetic retinopathy can certainly be leveraged if we improve our screening. So these considerations highlight the need for improved screening and access to specialty care for retinopathy and people with diabetes. Andrew, perhaps you can take us through some of these options for preserving sight.
Sure. So we're going to have a little bit of a longer, more lecture-style presentation here, talking about treatment options for diabetic retinopathy and diabetic macular edema. So when classifying diabetic retinopathy and diabetic macular edema, there's really non-proliferative diabetic retinopathy when it first starts out, and that is in the beginning just mild with a few little microaneurysms, a few little dot blot hemorrhages, moderate, where we see more of the same, and then severe, where it's like all four quadrants of the retina are consisting of retinal hemorrhages, and we're seeing other vascular changes in the back of the eye. But that's all non-proliferative diabetic retinopathy. When they start growing abnormal new blood vessels, pathologic ocular neovascularization, then those abnormal blood vessels start to bleed and leak and pull on the retina, and that's what can lead to severe irreversible loss of vision. And that's proliferative diabetic retinopathy, as the name suggests. There's proliferation of these blood vessels. Now, spanning both all the levels of severity of non-proliferative diabetic retinopathy and proliferative diabetic retinopathy, you can also have diabetic macular edema, which, if it involves the very center of the macula, can cause the patient to have a central visual blur or scotoma or distortion in their vision, and that is something that we have great treatments for. So in terms of standard diagnostic tests, we already talked about some of them here today, between just direct ophthalmoscopy, which ophthalmologists don't really employ so much anymore, but we do the slit lamp biomicroscopy, indirect ophthalmoscopy, where we put that coal miner's hat on our head and hold a lens in front of your eyes and take a look around the far periphery of the retina. And really, that's all you need to follow patients with diabetic retinopathy. But to detect the earliest stages of center-involved or center-threatening diabetic macular edema, you really need that test in the middle there, which is OCT. It's kind of like a CAT scan of the eye, except no radiation is involved. Gives you a cross-sectional analysis of the macula using light, and that's it. It's very non-invasive. You don't even need to be dilated to obtain an OCT, and we can very quickly tell whether there's any swelling of the macula or not. Occasionally, we'll do fluorescent angiography, as shown on the right, where we inject the patient with intravenous vegetable-based dye and then see how well their perfusion is and see if there's any abnormal blood vessels growing. So as I mentioned, OCT can detect diabetic macular edema, shown here on the left, with center involvement at a very early stage. And if it's present compared to that normal previous image I showed you, it's very easy to tell the patient, well, this is normal and this is what you have, and this is corresponds with your decreased vision. Oh, and look, you've gotten your blood sugar under control, and look how nicely this has improved even without any directed eye treatments. Or we gave you an injection last month and look how much it's improved. Don't you want to keep doing that? And so that's very intuitive for patients to see that, and it literally only takes about 90 seconds to get that image. And you can see a topographical thickness map associated with multiple OCT scans on the right. So yeah, OCT can diagnose both center-involved diabetic macular edema and center-threatening. So sometimes we'll see a little bit of edema just off the center, and we'll see that getting worse at each visit. And we can use that as a motivating tool to tell the patient, see how it keeps getting closer to the center? You got to change something, or we've got to start treating you directly in the eyes in order to get that under control. Here is a wide field fundus photograph showing just the far extent of the retina that's visible with just one single image. In the old days, we used to have to take 7 standard fields shown by these different circles here. And even when we summed all those up in a montage photo, we only saw like less than 30% of the retina compared to today's technology where in one image we can see this much retina. Almost 180 to 200 degrees of the fundus are visible with that one image. And it allows us to very nicely follow the level of severity over time. And we can do the same with wide field angiography. In this patient showing the early stages of proliferative diabetic retinopathy with neovascularization. So here's a normal fundus photo on the left. Here's a patient with diabetic retinopathy that's moderate to severe on the right with lipid exudate in the macula associated with center-involved diabetic macular edema. Here's the center of the vision, here's the swelling, and here's some other manifestations of diabetic retinopathy. So we have, these narrative descriptions of severity like, oh, mild to moderate, moderate to severe, non-proliferative or early or high-risk proliferative. That's how we describe things in everyday clinical practice. When we're in a clinical trial, we use the early treatment of diabetic retinopathy severity scale shown here, where it's numerical values ascribed to the level of retinopathy based upon standard fundus photos. And that's helpful at documenting efficacy of different medications. So what types of ways do we measure patients' clinical trials besides the severity scale? Well, the number one thing we're trying to preserve is visual acuity. So we often in everyday clinical practice use the Snellen visual acuity chart that you're all familiar with in your offices or in the emergency room or when you go to the eye doctor. But that's not really quantitatively analyzable in a consistent fashion from one doctor's office to the next. So we tend in clinical trials to use this ETDRS chart here, where it's very standardized, has standardized lighting conditions, and we use that in order to logarithmically follow these patients in a quantitative pattern. But it's not really pragmatic to use in an everyday clinical practice because it does require a standardized approach. So we're going to have a follow-up poll question as a breakup to my lecture. What would you now say is the preferred method of diabetic retinopathy and diabetic macular edema screening by primary diabetes care professionals? And your choices are number 1, Amsler grid, number 2, Snellen eye chart, number 3, direct ophthalmoscopy, number 4, comprehensive exam with qualified eye care professional, or number 5, I'm not sure. So go ahead and answer, please. Okay, so how do we treat diabetic retinopathy in 2022? Well, the first thing we do is make sure that they're connected with an outstanding diabetes professional, like my colleagues here, or their primary care physician, or I should say. So systemic control is paramount. If that is not doing the trick, then we have to do something. In the old days, we used primarily laser photocoagulation to treat diabetic macular edema and to treat proliferative diabetic retinopathy, but it wasn't indicated really for non-proliferative diabetic retinopathy. Now, for both non-proliferative as well as proliferative diabetic retinopathy and diabetic macular edema, we can do intraocular anti-VEGF injections. We generally don't do that until it gets to the severe non-proliferative stage or the early or high-risk proliferative stages. But we definitely do it for patients who have center-involved diabetic macular edema. And when that doesn't work, then we will go to corticosteroids to control the diabetic macular edema. and these are intraocularly delivered. And if that doesn't work, or if the patient's losing vision from traction retinal detachment or vitreous hemorrhage in proliferative patients, then folks like myself will do vitrectomy surgery on those patients. But by that point, you're really behind the 8 ball. So in terms of efficacy of these agents in preserving and improving vision, we know that for diabetic macular edema, these intraocular anti-VEGF agents, such as aflibercept, off-label intraocular bevacizumab, ranibizumab, and now faricimab, which is a bispecific molecule against anti-VEGF and Ang2, these medications work outstandingly well at not just preserving vision, but improving vision from where it had dropped when the center-involved diabetic macular edema became evident. And so they work quite well at improving vision. And this is a big change from when we were using focal laser photocoagulation, where really we were just reducing vision loss, not gaining vision. So this is a real revolution. And these are quite well tolerated and safe, despite what one might think when someone's talking about putting a needle in your eye, especially once a month to once every 3 months or 4 months or so. It's not something you would think that you would want to do, but it's actually surprisingly well tolerated. We use a 30 or 32 gauge needle. We prep the eye with betadine. So not surprisingly, these patients will have a little bit of pain and hemorrhage on the surface of the eye, but in terms of severe complications, they're quite low. But these are not durable therapies for the most part. They wear off quite quickly. And so we do lots and lots of frequent injections, like I said, every 1 to 4 months, depending on how the response pattern is. And we know that patients that get earlier treatment of their diabetic macular edema and or diabetic retinopathy have better favorable visual outcomes compared to those with delayed treatment.
Well, Andrew, let's go back to Zineb and see what she has to say about her experiences.
The laser really helps with my diabetic retinopathy. However, since it's a pro-inflammatory, it agitates the macular edema. And the macular edema is actually treated by the injections. That being said, the battle between the medication and the injection against trying to fix the inflammation that the laser causes is astronomical. Usually about a month after I've had laser, my entire vision is completely shot in the eye that I had laser in. And I need about 3 or 4 plus months of injections to bring that swelling down and bring the blood down. I'm actually still dealing with blood and vision loss that I had from my very first session of laser. So it's going, and it's not ideal, but I do it for the sake of saving my vision. This is probably going to be the most difficult question for me to answer. Realistically, it feels very bleak. Realistically. I do my absolute best to remain as positive as I can be regarding all situations in my life. I mean, it's a juggling act and I'm a one-woman circus at this point. But I try my best to remain positive and really, really trust the process.
Yeah, so her case is complex because she has both proliferative diabetic retinopathy, which did require heavy amounts of laser, which we still use for that indication. But as she mentioned, it can exacerbate the diabetic macular edema. So we have to use the intraocular anti-VEGF medications to help with that. And it is a bit of a long journey for especially a very young woman who is wondering, well, is this going to be like this for the rest of our lives, for the rest of her life? So, you know, her case is a nice example of one in which shared decision-making was super important because there were so many different issues that we had to talk about. We had to talk about, well, if we do the laser, it might diminish your peripheral vision and your nighttime vision. But on the other hand, if we don't do it, you might lose vision from bleeding in the eye and traction retinal detachment from proliferative diabetic retinopathy. But if we do the laser, it's going to worsen your macular edema. So I had to spend a lot of chair time with her explaining that some of these treatments are going to maybe make you feel worse for a while, and some of it may be permanent. But on the other hand, you need it. You don't really have great choices, but we're going to give you a series of choices that you can be involved in. And so this is where, you can't just be paternalistic with these patients, otherwise you'll definitely regret it. So you have to manage their expectations when there are multiple comorbidities within the same disease that are affecting her vision, as well as the side effects of those treatments. Now, most of the patients we're treating with these intraocular anti-VEGF medications don't have her complicated case where it's proliferative and bleeding and so on, where it's really just treating either the earlier forms of diabetic retinopathy or just mainly the diabetic macular edema. But in any event, you really do have to set their expectations, because no matter how many times I'll tell a new patient who's getting ready for injections this is a treatment that's controlling your disease. It's not a cure where I'm going to give you 1 or 2 injections, then you'll be done. They'll come in on the 3rd visit and they'll be like, this is my last one, right? And I'm like, well, no, this is kind of like something we're going to be doing probably for a number of years, if not longer. So you really have to constantly set their expectations and manage them appropriately. Because the more engaged the patient is, the more educated they are. We can tell from surveys like this one that are available that getting the patient involved in their care, letting them know the numbers that we're interested in. What's your A1C? What's your blood pressure? When's the last time you saw Dr. Fonseca? When are you going there next? It is frustrating that even my own endocrinologist that I work with at USC, a lot of these patients have so many visits in the electronic health record that I have to scroll for 6 pages in order to find the endocrinology visit. And meanwhile, I'm trying to get through this busy clinic. So it's very difficult to, even in the same system, to communicate effectively and to share information. So that's something where we can definitely improve. And I think it'll be helpful going forward. But let's transition over to my colleague, Dr. Fonseca.
All right. Thank you, Andrew. Before we do that, I just want to spend 1 minute having each of us comment on how we integrate in our various practice settings. Because I know for me at Joslin, I actually live in 2 worlds. When I'm practicing at Joslin in Boston, we have our Beatham Eye unit, Beatham Eye Institute in the same building. We use the same record. So I can take a look there and see what the ophthalmologist is saying, what the interval of visits are. But we also go out to our satellite in a suburb of Boston, and there the patients often will go to various ophthalmologists, and I get very poor feedback. They often don't send the records. I don't know exactly who they're seeing, and so it's really a dichotomy of experiences. Vivian, what about you here in New Orleans?
You have a dichotomy. I have schizophrenia. It's really very confusing because there is no ideal system. And we're trying I thought with EMR, and it's coming that we would be able to look at everybody's chart. Now, I work part-time in the VA system, which is a closed shop. Like your same building, in the same record, I can see what's going on over there very easily. But I also work in the university's private hospital and a state-run hospital. And that's very complicated because you don't know when. You ask your patient, do you want to, I'd like you to see our ophthalmologist. They say, I already have my own eye doctor. I like Dr. Moshfeghi so much, I'm not going to see anybody else. And that's fine. You got to respect that decision. But if I can't see your records, I don't know. And what I'm going to talk about now in a moment is there are things that we can still do that's very important. And you need to know that we are doing that.
Before you do that, Andrew, what's the situation in your institution?
Yeah, no, we're essentially a closed shop, but only with respect to the physicians that the patient is seeing. So for example, we have a lot of patients who come in maybe for a kidney transplant to USC, but they're coming in from Bakersfield, which is like, 2.5 hours away, and all of their other care is there. So even though, yes, I can see the other stuff that's happening at USC, that might not be the totality of their other care. So I still have the same schizophrenic situation that Dr. Fonseca referenced with respect to a large proportion of my patients. But for the ones where I can see it, yes, I can see my colleagues' notes, and I can see the lab work, and that's nice.
So Vivian, perhaps you can comment a little more formally on how we can coordinate care more effectively.
So we've talked about this a long time, multidisciplinary care with the patient in the center and having multiple specialists and primary care physicians integrated around this. Primary care physician I'm an endocrinologist, a specialist seeing only endocrine patients. I just can't keep up with the vaccinations and other things that are patients with multiple comorbidities, and that's challenging. So I encourage everyone to have a primary care physician. We need pharmacists to handle all the multiple drugs that patients are getting. We need our diabetes educators, the nurses who manage these patients, the dietitians, the podiatrists. Then we get around it. Often patients need a cardiologist and a kidney specialist and ophthalmologist. And the patients really burdened with all this. They almost have to come to see some doctor or a medical person every day. And it's very, very challenging for them. And if there was, I wish we can get a better way of having a handle over what's going on exactly so we can coordinate things better. I want to point out that it's not as if I hand the patient over to the ophthalmologist and I forget about the retinopathy. There are multiple things that are important. So first of all, glycemic control. It's never too late to give up on glycemic control. I want to point out that you might get transient worsening if you take somebody who's very well controlled, very poorly controlled, and then acutely control them. That was seen in the DCCT for the first 2 to 3 years, but after that, things got better, and at 9 years, the intensively controlled group was much better as far as their eyes are concerned. So don't worry about the short term. Obviously, you have major surgery, you're not very well for a little while, but then you get better, and your long-term outcome might be really much better. So that's the way I explain it to my patients, that you need to watch out for things worsening. This is the time for you to go and see your eye doctor and also make sure that there are other diabetes complications are managed. Now, in improving glycemic control, we need to think about what could happen with the medications that we are using. And I mentioned insulin in type 1, people not being very well controlled, then suddenly well controlled, getting worse. Some of the drugs like thiazolidine downs a few years ago worsened diabetic macular edema. And recently we've had a few reports from clinical trials with GLP-1 receptor agonists showing that with some of them, and I think it's really the more powerful ones like semaglutide and dulaglutide and maybe liraglutide, longer acting, more powerful, that might have some of these effects with worsening retinopathy. Now, I want to point out, first of all, that the absolute rate of this occurring is very, very low. And it occurred mostly in people with prior retinopathy and not, as you can see on this slide, in people who didn't have prior retinopathy. So sometimes I have patients who say, I want to have this medication that my friend is taking that's doing very well. And I say, sure, I think it's a great medication, but you need to have your eye exam, which you haven't been to see Dr. Moshfeghi for the last 2 years. This is your time to go. And if he says you don't have retinopathy, we'll get you started right away. If you have retinopathy that needs treatment, I think we should wait a few months till you're stable and have your treatment and then use that. And that's what's actually happening in clinical trials with these agents right now. People are not being included if they have retinopathy, and they won't see this problem, but that doesn't mean the problem won't occur in the people with severe retinopathy. On the flip side, we have some very intriguing results with fenofibrate. Now, fenofibrate is sort of out of favor because we have better lipid-lowering drugs. But in the field study, which did not reduce the primary endpoint of cardiovascular events, there was an improvement in retinopathy. And a few other trials with fenofibrate showed that retinopathy rates were higher in people in the placebo group than people in the treatment group. It's actually quite striking, the results, but this was not the primary endpoint, so this is not an indication and not an FDA-approved indication for using fenofibrate in people with retinopathy. But it's something that we need to keep at the back of my mind. We can't really make a strong recommendation about it. It's very interesting. This is a PPAR alpha antagonist. They have PPAR gamma with thiazolidine downs, and both receptors are present in the eye. There's a very nice review a few years ago in the New England Journal talking about PPAR in the eye, and one making things worse and one thing making things better, so better targeted therapy may be what we need. And there's not enough data with the other drugs like SGLT2 inhibitors, et cetera, but blood pressure lowering in general is good for the retinopathy, but even within there, people who are taking RAS blockade, particularly with ACE inhibitors, tend to have less retinopathy, the incidence, progression, and perhaps even, maybe a little bit of regression in some people, although that's not striking, and this is obviously not an indication. You're treating the blood pressure, and maybe you're preventing cardiac kidney disease, where it is indicated for. And a bonus is that your eyes might get better, and this has been seen for many years in many trials, and is useful. So we get around to the other problem. You're taking care of the glycemic control. What else can we do to navigate this communication issue without breaching laws like HIPAA and so on? Now, one of the problems I think Andrew alluded to just now is we have a large proportion of our country is rural. And these people don't have access to retina specialists. It's fine for us to stand up here and say, everybody should see a retinal specialist if they have diabetes. But many people don't have that access. Even in an inner city, poor urban neighborhood where I work, there are not many retinal specialists, and those who are there have long waiting lists. So we need to utilize things like telemedicine, et cetera, to identify which particular patients we can send so that they can be seen quickly. So this is the density map of optometrists. Still not some areas without them, fewer ophthalmologists, and very few retinal specialists across the country. So telehealth is important. We have this in some of our clinics. The staff is trained to take the picture. It goes up to the cloud. It's read remotely. A letter goes to the patient. A letter comes back to the referring doctor. This is actually more efficient than sending the patient to the retinal specialist, who might not send all this information back or tries to send it, but it doesn't quite get to me because there's a small spelling mistake in the patient's name or something and doesn't get filed in the right chart. So telemedicine has greatly expanded. There are companies that run this service, and COVID-19 really brought this out to the fore. Patients didn't want to go for more exams. They were seeing me remotely, and I said, you need an eye exam. But now you can do the eye exam remotely if your patient went to a place where they could have their photograph taken and then identified as needing treatment, and only then having to go and have that treatment. So I think this highlighted the importance of this remote patient management, particularly for patients who have mild disease and are stable. Maybe that will decrease the burden on the system. So a lot of value in this, and this value has been shown, as Rich pointed out, in a closed system like in his institution in Boston. There's a lot of value. You can manage that. I manage it in the VA system, but I don't across the street in another system which doesn't have that integrated system, and patients go to all different ophthalmologists across the city. And now we're having a lot of developments using things like artificial intelligence that can recognize these figures, read it instantly, give you an answer instantly. We tend to still have some degree of lack of confidence in this whole system. Is this computer making a mistake? And I hear this a lot from my colleagues in medicine. yet they'll rely on Google telling them what to do and things like that. So I think we need to, keep an open mind on this to see how we can make this, improve the efficiencies, because we're not doing a good job right now. So we need this communication, the feedback. We need the referral from the diabetes doctor to the ophthalmologist, and we need the feedback. Yes, your patient is stable. Your patient can now go on a GLP-1 receptor agonist. Here's what I'm planning to do. I'm going to give laser and a VEGF inhibitor, something that I'm seeing a little bit of, but not a lot. There are some potential adverse effects. We often worry, you're blocking VEGF, and maybe you can answer it. We need VEGF, and your patient's got ischemic heart disease. You want new vessels to grow, but they don't need to be growing in the eye. They need to be growing in the heart. So what are we doing when we're giving things that might leak out into the systemic circulation? Is there interaction with other comorbid conditions? I'll give you a classic one. A patient on hemodialysis having anticoagulants may have greater bleeding, and the ophthalmologist needs to be told whether this particular patient is having very powerful anticoagulants right now. So maybe, can we do anything to help optimize these outcomes? So capturing metrics is very important. I'm all for simplicity. I wish we could have all this on one little sheet of paper where the right person fills this in. One of our EMR systems actually has 2 drop-down boxes which we have to fill in every year. One is on foot exam and one is on eye exam. I don't have to put in my findings. I just say, Dr. Moshfeghi has seen the patient on this day, and the patient doesn't have retinopathy. That completes what I need to do. So we need to have best practices for managing these referrals, follow medical society guidelines, although you heard there's confusion among the medical societies. But actually, when you look at it, the differences are not large. The basic principle is people need screening so that they can get appropriate treatment. Recognizing who's urgent, I think, is critical. And if the patient reports certain things like new persistent multitude of visual floaters, any decreased vision that's coming on, particularly coming on suddenly, severe eye pain, there are people where I will look into the eye because I grew up and got trained doing that, but I think maybe I'm not doing it often enough and I don't have enough confidence anymore, but I will then pick up the phone for certain patients and say, this patient needs to be seen pretty promptly, and then follow up. So this is, we go back to the cases.
Yeah, well, we will in a second. Andrew, I just wanted to ask you before we get on to the cases, from your perspective, what sort of information would you like from the primary diabetes care provider?
Yeah, no, I think if we say what is it we ask all of our patients, number one, what is your most recent A1C? How long ago was it? Was that trending upward or downward? Any changes in medications? Things that I might not have access to in my own electronic record if they're one of those outside patients. Blood pressure, and how are their kidneys doing? Those are the main things.
I mean, one of the things that I recommend to my patients, because everyone is in such scattered medical care settings with HIPAA barriers, and you can't get, even within the Beth Israel Deaconess system where I work, you can't get information from one setting to another. Be their own medical record keeper. Yeah. Keep records, ask for the results, keep them in a folder, bring them to visits. You never can tell what's going to be needed, and it saves so much work.
I'll tell you one thing that's actually been great is the patient portals. Patients will actually bring them up on their phone while I'm sitting there in the office with them, and that's been super helpful, especially for the tech-savvy patients.
Exactly. Well, let's go on to a couple of cases in the last few minutes that will help illustrate some of the issues that we've been talking about. We're going to start with Elrod, a 67-year-old black retiree with type 2 diabetes. 7-year history of type 2 diabetes, glycemia, blood pressure, and lipid levels are currently well managed on metformin, GLP-1, and losartan and hydrochlorothiazide, and rosuvastatin. Patient doesn't report any visual problems. He admits that he's procrastinating on scheduling an appointment with an ophthalmologist for a comprehensive eye exam and doesn't want to go out during the pandemic unless it's essential. So the visit notes, no history of retinopathy or macular edema. Visual acuity in the in-office eye chart is 20/20 with his current eyeglasses, unchanged from his last visit. So if we think about this sort of setting, the first question, I guess, is how urgent is the eye care referral, and what clues here might suggest increased urgency? Either of you.
Yeah, I don't think it's critically urgent, but the patient does need an eye exam. And I think if you're in a practice that has many patients like that, and many people do, some investment in a camera may be worthwhile. It may be that if you're in several primary care physicians in the building, you together might be able to afford to lease one. And it's not a major financial loss then.
Yeah, and so his risk factors are he's on lots of medications, including a GLP-1 medication. He does not, sounds like he hasn't been in a while. It's hard to tell whether this was his first exam or...
Yeah, it's the COVID effect. He hasn't been
Yeah,
delaying. And
it's been a while. Even though his vision is good, as I mentioned earlier, he might still have some peripheral retinopathy.
And how can you overcome the complacency about this, Vivian? Overcome the complacency. How do you convince this guy?
I think it's all about education, and that should be part of the general diabetes education of the patient, and pointing out the risk factors.
Yeah. And Andrew, you see this gentleman. How do you make sure he comes back in a timely way?
Well, you have to educate them, which sometimes ends up scaring the patient a little bit. It's not really my goal, but I do find that to be a little bit effective at telling them that, there is the reason where all these different doctors are telling you to come and get this eye check isn't just to check a box, but because there's a real risk of severe irreversible loss of all of your vision in the extreme case, and we can totally prevent that. And I tell them, look, I promise you one thing, if you keep coming back on regular visits, the likelihood of you losing your vision is quite low.
Let me turn things over to you for a minute, Andrew. You talk about lack of knowledge. How do you intervene in that a little bit more effectively?
Well, one great thing with digital imaging and the OCT images I showed you before is I always have available reference normal on another screen. And I'll show them, their image, and I'll show them the normal image, and it's super easy for anybody to see the difference. And so that's really more for the patient with retinopathy or with diabetic macular edema. For the patient who's totally normal, then I just kind of tell them, I'll show them different examples of diabetic retinopathy and say, this is what we're trying to prevent, this is what we're trying to avoid. And usually that's fairly convincing. Whether they're actually going to come back, it's hard to say. We have to follow these patients for long periods of time in order to get that data.
And patient resources?
Yeah, so we have pamphlets and websites, and our own website has a lot of information about all that. So we do share that with them, as well as just from the EHR itself.
All right. And now, at the beginning of the program, we had this first question. Let's come back to it. 67-year-old man with 7-year history, type 2 diabetes, well-managed glycemia, blood pressure, and lipids, annual exam. Visual acuity is 20/20 with his current eyeglasses, unchanged from his last visit. His retinas look normal under ophthalmoscopy. Now, what is your next step? And again, let's see what people say. Document normal retinas, make a non-urgent referral to an ophthalmologist, make a non-urgent referral to a retina specialist, or 4, make an urgent referral to an ophthalmologist, 5, urgent referral to retina specialist, or not sure. All right, Andrew, what would you say you should do in this circumstance?
Yeah, so this is a 67-year-old patient, 7-year history, well-managed, good control, 20/20, no change in his vision. So really, you can take the urgent referrals off of the equation here and then focus on the other three choices. I don't like option one for the same reasons I said before. You're only documenting normal for what you can see. So in my opinion, it does not satisfy the annual eye exam being normal criterion. So really the question is, should we make a non-urgent referral to an eye care provider like an ophthalmologist, or does it have to go to a retina specialist? It'd be great to send everyone to a retina specialist, but as Dr. Fonseca pointed out, there's only a couple thousand in the whole country. They would be inundated just from this alone. So really, choice two is a good choice in this patient. Non-urgent referral to an ophthalmologist.
All right, let's go on to the next case. This is Lizzie. She works as a horticulturalist, manages her seasonal allergies with her PCP. Type 1 diabetes has not been optimally controlled using a sliding scale of basal bolus insulin. She attended virtual on-site visits to learn carb counting, recently started using a continuous monitor and a hybrid closed-loop system. A1C went from 9.5 to 6.8, good for her. Diabetes specialist managed the advancement of her glycemic control treatments and assured her that seasonal allergies and type 1 diabetes can contribute to varying visual symptoms. She's not received a dilated exam in over 2 years because of COVID. So visit notes, scheduled appointment for routine diabetes specialty care, and mentioned seeing some floaters. Has ongoing intermittent episodes of blurred vision because of seasonal allergies. Visual symptoms did not seem to be improving. So how do we deal with this? How urgent is this eye care referral, and where should she be referred? Vivian, if you saw Lizzie, what would you think?
You know, I think this patient has, several pointers towards needing care fairly soon, not ignoring it, as well as improving the overall diabetes management. So I think both factors come into play there.
There's a concern, I think, Andrew, with respect to retinal detachment, and what signs and symptoms here might make one of us diabetes people concerned that could be happening.
Well, it sounds like she's having new floaters, and that's definitely concerning for either vitreous hemorrhage or forms of retinal detachment. And as you pointed out, this patient needs to get seen relatively quickly. Lots of risk factors here. She had intensive control all of a sudden, 9.5 to 6.8. Yes, she has these comorbidities of allergic eye symptoms that she's self-diagnosing, but it may not be that. It may be diabetic macular edema or vitreous hemorrhage or something else. So that she needs to get seen pretty quickly.
For urgent care, would this be someone you might even send to an emergency room, or how would you handle it if you thought this was really
Your heart is in the right place by thinking about that option. The problem, the pragmatic reality is very little ophthalmic care is delivered in an emergency room or urgent care setting. So you're better off reinforcing to the patient another good reason to see an ophthalmologist every year is so that when something like this happens, it's easy for you to get in to see them after hours or on the weekends or whatever. And so that's another reason to sort of reinforce the annual exam.
I think rather than going to urgent care, the patient is better off if you were to call or email the retinal specialist and say, I have somebody who needs to be seen.
Yep, I agree.
right? And telemedicine's role in this, Vivian?
Pardon?
Telemedicine's
I
role?
think this is a little beyond telemedicine. Telemedicine is great for routine screening. What am I going to get back? I'm going to get a recommendation that the patient needs a retinal specialist. I already know that.
Right, so it's sort of the anticipatory approach is better here so that when you start seeing things that are worrisome, you've got a route which you can follow.
It's evaluating risk, and I think the risk here is very high.
Yep.
Okay. So let's, Andrew, I think the next couple here, signs and symptoms of potential emergencies?
Yeah, so for a diabetic patient who has a painless decrease in central vision, you might worry about diabetic macular edema or cataract, or just a change in their refractive status as a result of labile glycemic control. But like that last case, if a patient especially has unilateral sudden onset of flashes of lights and floaters or visual field defect in one eye, although diabetic retinopathy can bilaterally simultaneously present itself in a bad way, it usually doesn't. It's usually one eye and then the other. So typically that's something to ask the patient, well, which eye is it that's bothering you? When did it happen? So we're looking for flashes of light, floaters, curtain of darkness in their vision, and central blurring is really more of a gradual onset of diabetic macular edema, and that's less of an urgency.
Okay. And then the after hours, I think we covered most of this.
Yep.
Okay. Another case, 59-year-old woman with 9-year history, well-managed type 2 diabetes, reports an annoying but painless blob moving around her left eye and partially obscuring her vision. She also mentioned seeing flashes of light in her left eye. What is your next step? That certainly gets my attention, and we've got the same options here. One, reassure her that flashes and floaters are a normal part of aging. 2, non-urgent to ophthalmologist. 3, non-urgent retina specialist. 4, urgent ophthalmologist. 5, urgent retina specialist, or not sure. Okay, Andrew, what is your thought on this?
So the ideal answer, I would say, is number 5, but in the absence of a retina specialist, it would also be reasonable to have an urgent referral to an ophthalmologist. The patient's symptoms are concerning for, at the very least, possible vitreous hemorrhage from proliferative diabetic retinopathy versus possible also retinal detachment. So that needs to get further evaluated quickly.
Yeah, I mean, I think, my initial wisecrack when I was presenting this about the blob moving around her eyes, even us diabetes specialists, that we pay attention to that. So I think that would be...
We'd have to admit we don't know what's going on.
Right.
Doesn't happen often, though.
Right, we don't say that often, but, whoops, this doesn't sound good. And again, I think some of the points that we made in the prior case, this one just sounds a little bit more urgent.
Yeah.
If you've set up the referral pattern and they've got a regular ophthalmologic practice, ophthalmologists, even if it's weekends or holidays, have people on call.
Yeah.
They can accommodate them appropriately. And I think that's an important consideration. And again, for this circumstance, the telemedicine approach wouldn't help. However, what if they live way off in the middle of nowhere? For me, it'd be the backwoods of Maine, here in Louisiana somewhere, or the rural parts of California. Would a telemedicine exam at least start a process going, or should they just get in the car and go?
Yeah, I mean, it would be difficult to get, you're saying in the endocrinologist's office?
Oh yeah, or even a primary care provider in the distant.
In my opinion, they need to get in the car and go.
I agree with you. I come across this a lot, and I tell people, you've come to see me, and I can't do much for you. You got to go and see somebody who's going to help you.
Yeah, the telemedicine things, while in really extenuating circumstances, could be used for examining the retina in an urgent situation. It's really more for screening.
So let's, in follow-up, ask the question, how confident do you now feel, now that we've listened to this conversation, about the ability to screen for our people with diabetes for diabetic retinopathy or macular edema and make a referral consistent with current guidelines and evidence? 1, not all that confident. 2, not very confident. 3, somewhat confident. 4, confident. 5, very confident or not applicable. All right. So now let's clicker's not behaving here. How confident are you in your ability to differentiate between the need for an urgent versus a non-urgent referral to an eye care specialist? 1, not at all confident. 2, not very confident. 3, somewhat confident. 4, confident. 5, very confident. Or 6, not applicable to me. Okay, so we've captured that information. Just to summarize, a couple of key points that I think are important as take-homes. First of all, it's important to connect with an eye care provider. And as you heard from some of those cases, when things start getting a little urgent, to have already an established relationship with an eye care provider, have baseline exams, have regular follow-ups, that's important so that there's a natural course for people to follow when things become urgent. Prevention is certainly best, and early detection and intervention are second best if prevention can't occur. And we've talked a lot about some of the preventive strategies, both for the diabetes care provider and for the ophthalmologist perspective. Stay organized and track key metrics. For those of us that are caring for the people with diabetes, make sure that they are seeing eye care specialists, the proper kind of eye care specialist. Make sure we know what's going on. Even if we just track when the eye doctor, quote unquote, wants to see them next, gives us a hint. If it's once a year, that tells us something. If it's 6 months or 3 months, that tells us there's a little more urgency from the perspective of the eye care provider. And our role, of course, for those of us here at the American Diabetes Meeting, I'm sure we buy into the concern about controlling blood sugar, blood pressure, eating a healthy diet, and staying active. So I think these are important key points for those of us caring for people with diabetes to be more effective in early intervention to prevent eye disease, and if not prevent, then to try to treat as early as we possibly can. Well, thank you everyone for listening to the program today. We now have a little bit of time at the end to go through a few questions from the audience. And I've got a number of them coming in that look very interesting. And I'll ask the faculty to give us their comments. One here that I think is very important, it was taught that tight glycemic control or aggressive or physiologic control, whatever you want to call it, can worsen retinopathy. Is that still a concern? Does it hold true? And if so, what happens and how do we handle that? Maybe I'll ask both Vivian and Andrew to comment on this. Vivian first.
This is a very important question. It was this phenomenon was first described in the DCCT and other type 1 studies, where initial worsening was seen when people who are very poorly controlled were suddenly well controlled. And it occurred for the first 2 to 3 years of the DCCT. And then later on, those people got better with the good glycemic control. So the long-term outcome remains very good. This phenomenon has not been described in type 2, and in fact, intensive glycemic control in studies like ACCORD actually showed an improvement in retinopathy and no worsening, not even transient worsening. Recently, in some of the GLP-1 receptor agonist trials, we've seen this be described, particularly with semaglutide, liraglutide, and maybe a little bit with dulaglutide. So, but not with the others. Now, it has been attributed to the same issue of tight glycemic control after poor control, but I'm not sure that that holds true in type 2. And it might just be related to the powerful agents that I just described. And maybe we need to be cautious. And what I'm doing is I'm referring these patients to get an eye exam before I start them on therapy. If they've had an eye exam in the last 1 year and they don't have retinopathy, there's no problem. For people who have just background retinopathy, again, I don't think there's a problem. But people having active treatment for their retinopathy, I try to defer therapy for a little while.
Andrew, what's your perspective on this?
Yeah, no, I agree with Vivian's comments. I would say that anecdotally, in our type 2 patients who get intensive control, even though we lack the rigorous data that we had the DCCT for type 1, that we do see that intensive control does generally increase one's risk for temporary worsening. For example, a great example of this is someone who has gastric bypass surgery who may lose 100 pounds and have a huge improvement in their A1C in a very short period of time. We have seen those patients have significant worsening in the type 2 population. So that is a concern. It is still an issue, but it doesn't really have to be something that's of major concern so long as the patient is being appropriately followed. So I think what Dr. Fonseca mentioned in terms of getting those patients to the ophthalmologist or retina specialist is important. And then depending on how much of a change we see, if any, in the setting of that intensive control, then we can titrate when their next surveillance exam ought to be, which may be different from those general guidelines that we get from ADA and American Academy of Ophthalmology and so on. So we just kind of tailor it to the patient in that context.
I know I was actually an investigator with the DCCT, and our mandate was to try to get our subjects into control very rapidly. And that's when we saw some of the early worsening. Would there be a rationale for when there's someone with active retinopathy being a little slower in trying to achieve optimal control? Either of you.
Yeah, I think that makes a lot of sense. I mean, if somebody's been poorly controlled for 10 years, why do we need to control them in 3 months outside a randomized trial that is intent on doing that? But that happened in the Accord trial, for example. And although we didn't see worsening of retinopathy, we saw increase in mortality and hypoglycemia. So for multiple reasons, I think we need to go a little slow sometimes. We have powerful tools today. We just need to go a little bit slower. And I use this as an opportunity to tell people, look, your eyes might get worse. So why don't you go and get your eyes examined? You haven't had any eye exam for 2 years.
Yeah, and there are a lot of protocols for insulin adjustment where they, adjust it every 3 days or something like that. And, some of those things are in the guidelines, but may not necessarily be practical or even such a good idea. But I know that they're meant to avoid some of the clinical inertia that 3 days becomes 3 years, and you don't want that to happen. So there has to be a happy medium in there somewhere. There are a number of questions here, and Vivian, you alluded to this, regarding the GLP-1 receptor agonists. And people have been asking, should we not be offering the GLP-1 receptor agonist to patients who have retinopathy? At what point do we think of different treatments? And perhaps you can elaborate a little bit on the safety of the GLP-1s.
So in general, they are safe. In fact, they have many good qualities like weight loss, improved cardiovascular risk, and so on. So I think we should not avoid using them for this reason. We should be cautious in people who have active, fairly advanced retinopathy, particularly people who are having treatment. And of course, in people who haven't had an eye exam, I just tell them, get the eye exam done. And then if it's clear, we will get started on this.
Yeah, I think the magic word that you just said was people that have active eye disease. Patients should be monitored. And if they have active eye disease, regardless of the treatment, I would make sure they're watched closely. And it's curious that it's come out more with the GLP-1s, but rapidly improving control with any tool, I think, has to be taken with a little bit of caution. All right, let's see what else we have. Questions here. How often should a dilated retinal exam be performed by an optometrist, they're asking, or should it be done by an ophthalmologist? Perhaps, Andrew, you can clarify what the recommendations are on those issues.
Sure. So it's not so much, who does the dilated exam. It's really a question of, what is being performed during that exam. So if the person performing the exam is competent to carry out that exam and determine whether or not and what the level of retinopathy is present, then it should be done according to the society guidelines, whether it's ADA, meaning with the history of no retinopathy type 2. You'd see that patient around the time of diagnosis and then annually thereafter, or even biannually in the absence of no retinopathy according to ADA. But it depends on the level of the retinopathy more so than the type of provider that's carrying it out. But in many respects, we rely upon, for our optometry colleagues, their comfort level in following patients with diabetes and diabetic retinopathy to determine, that they are able to effectively carry that out. But by and large, this is something that can be done annually in patients with no retinopathy and more frequently commensurate with their level of retinopathy according to the guidelines.
And Andrew, when after someone is diagnosed with diabetes, do you think they should start with the regular ophthalmologic exams?
With our type 2 patients, when they first find out that they're type 2 and they might have a very poor A1C level, it's presumed that they may have been walking around with that diabetes diagnosis for months or years. And so because we don't really know how much retinopathy may be present in those patients or whether it's present at all, we recommend at the time of diagnosis. So really in that first year that they're finding out that they have diabetes, that they should get that exam. I'm sure amongst many other recommendations that go outside of ophthalmology. For our type 1 patients who tend to present more acutely with diagnosis, they're not typically walking around, at least my understanding that this is the case. It's really more your guys' bailiwick that, they are less likely to have diabetic retinopathy at baseline. And so for them, within the first 5 years or so, it's reasonable to get that baseline exam and then get reconnected according to what is seen on that first exam.
Yeah. Now, is there anything, there was a question here. Is there a role for the family practice, general practice provider in doing ophthalmologic screening or checkups? And if so, what would that role be, looking in the eyes in the primary care office?
Yeah, the problem is that it's fine for primary care doctors to examine the fundi with a direct ophthalmoscopy or any other method, but that really should not take the place of the annual screening exam unless they're participating in a telemedicine type of program that's well validated. But in terms of just looking with a direct ophthalmoscope, it's only helpful if they see retinopathy. If they don't see retinopathy, they cannot be confident that there is no retinopathy because you can only see maybe less than 10% of the retina when you're looking with a direct ophthalmoscope. And a lot of the retinopathy may be predominantly peripheral in location and well outside of your capability to see that. So it shouldn't suffice. It's fine to do as part of your exam, but it shouldn't replace the annual screening exam.
I guess that also, to some degree, addresses another question here about whether a worksite occupational health clinic could be a site for retinopathic screening. That would be similar to a primary care office.
I think that would be fine. One of the problems there is communication of those findings. So, when you go to see your ophthalmologist that you're always seeing or the optometrist that you're always seeing, there tends to be a relationship between that person and, the endocrinologist or the primary care physician. But when you're in one of these ad hoc, community screening programs, you may not be connected. And so you may have had the finding, but it may not have been properly communicated back to the PCP or the endocrinologist.
Okay, I think that really underscores a theme of this program, and that is
I think what Dr. Beaser was summarizing there was that our regular examinations is of paramount importance, and also that communication between the diabetologist and the ophthalmologist and optometrists is important. And so, and communication with the patient, we're bad enough communicating with each other between different subspecialties, but we also have to remember to keep the patient in the loop as well and reinforce the need for follow-up. And going back to the questions about the GLP-1 and agonists in terms of worsening of retinopathy, as long as the patient's being followed and there's communication between the diabetes doctor and the ophthalmologist, hey, I want you to see this patient because we're putting on something that's going to make intensive control quickly. Do you mind letting me know, A, if that's okay, and then B, when they need to be seen again? I think that's fine. We just need to make sure that we're following those patients closely over that time and reinforcing to patients that regular eye exams are paramount importance.
Thank you, Andrew. My computer did a little blip here, but I think we've run out of time, and I appreciate the great input from Vivian and Andrew and the audience for their terrific questions in response to this program.
Thank you. Thanks.
Thank you.